All right, well, welcome everyone to our first knowledge exchange of the fall semester. We had one that was canceled earlier, but don't worry, it's coming back in November on harm reduction. Today's event is really focusing on a critical issue for health professionals. And we are going to be learning today with and from forensic nursing on sexual assault and forensic nursing, what all health professionals need to know for better patient outcomes. And although you'll be learning about a specific role that nursing can play, we want to make sure you know how important it is to all of us who are gathered here today. Before we start, I want to give a little bit of a shout out to our friends at the Co-Occurring Services of Maine, CCSME, who are helping us with continuing education units today. And also to our alumni who might be here in the audience. And if you are an alum of UNE and you'd like to put your name in the chat, we would really like to know that you're here. I want to encourage everybody to open your screens, especially when you're in the breakout sessions. We'd really love to have a lively conversation, an interactive experience. We will hope that everybody participates. And there will be a link at the end for attendance, which we hope you will sign off on. So again, I'm so appreciative of Polly and Sean to be here today. Thank you so much. And Polly, I'm going to pass it on to, oh, sorry, before I do that, we know that this is a very critical and maybe a difficult topic for many people in the audience. I mean, it's difficult for all of us, but for people who have been exposed or experienced or know people. So we want you to know that the UNE counseling services are available to you, and that we promise you that if you call the counseling number, a real person will answer that. And all the contact information is right on this slide. So don't, and if you need to step out, please do so. All right, so now, Polly, I'm going to hand it to you. Thank you.
Great. Thank you so much, Shelley. And thank you to the center for offering to let Sean and me talk about this. Our third team member is not with us. She might be here on the Zoom call, but Sean and I will be presenting. I've been a nurse for many, 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 many decades, but I've been involved in interpersonal violence work for almost 40 years. Specifically in sexual assault work for over 20. I'm very active in state and national boards and task forces in promoting better services for victims of all kinds of interpersonal violence. But today we'll be really focusing on sexual assault forensic nursing, which is kind of foundational to all other interpersonal violence work that we do.
And I am Sean Johnson, and I am a sexual assault forensic nurse and also a regional coordinator for the UNE SANE program here. I've been a forensic nurse, it's a little over 8 years now, and I've been in healthcare in some aspects for almost 17 years now. So I want to say thank you for having us here to talk about this very important thing. And I'm going to turn it back over to Polly.
Great. Will I be advancing the slides? Okay. So today we'll be discussing a little bit about why we have forensic nurses here in Maine. How did it all start? And the roles and responsibilities. How do we provide care, and where is that care provided? We'll talk very basically about medical forensic care following sexual assault and abuse across the lifespan. So thank you all for being here to learn more about who we are across the state and about sexual assault. So the purpose of our grant, and we received this grant in 2018, and we've been refunded in 3-year cycles, most recently this summer. So we're starting our 7th year. But our overall goal is to enhance the recruitment and retention of forensic nurses throughout Maine. It's a really difficult role to take on, and the nurses need a lot of support. The forensic nursing program that is run by the state, which has been around for over 20 years now, I ran that for 16. We work very closely with them to support nurses. We offer a couple of courses, they're 40 hours. We do a lot of simulations with the nurses, clinical simulations, and we offer a variety of 2 and 3 hour educational sessions on various topics throughout the year. Next slide. Thanks. So this is the state program. They provide a lot of education as well as some of the 40-hour courses. We're going to be doing 4 adult adolescent next year and 2 pediatric. So we cover the whole lifespan. When we think about forensic nursing, people think of the word forensic and they often think of NCIS or CSI, but really what it pertains to is crime and civil cases, mostly criminal court proceedings. And nursing, of course, is the diagnosis and treatment of human responses to actual or potential health problems. So when we think about forensic nursing, it's a marriage between the two. I want to emphasize that particularly here in Maine, forensic nurses work for hospitals. They do not work for prosecutors. They do not work for law enforcement. They are working for hospitals as nurses. So forensic nurse, we specialize in the care of victims and perpetrators of trauma. This trauma can be intentional or unintentional. We're very skilled at identifying very subtle injuries oftentimes. And we work closely with prosecutors, so we help them create their cases if a case is going forward. We take care of immediate needs. People think often that we collect evidence and that's pretty much all we do. And that is a very small part, an important part, but a small part, and it is not our priority. Our priority is the physical, emotional, psychological, and spiritual care of that patient. So we are nurses first and foremost, and that's sometimes hard for nurses who get involved in this. They think, oh, it's going to be like NCIS, and it's not. It's nursing, period. So these are our roles and responsibilities. And number one, of course, is to avoid any further trauma. We're very trauma informed, both in our care and our language. We know how to provide medical forensic care, do that exam, that head-to-toe assessment, identification of injuries. We work closely with the advocacy community, the sexual assault advocates. Hospital policies all say you call the forensic nurse and you call the advocate, because when the patient leaves the hospital, we may never see them again, but the advocates are there for the rest of that patient's life. And so often sexual assault survivors need advocacy off and on for the rest of their life. And we want to introduce that early on. So we know how to make referrals, and we're also really good at courtroom testimony because we work so closely with law enforcement and prosecutors. So a little bit of history of forensic nursing. Forensic nursing started back in the 70s as a response to the epidemic of interpersonal violence. It was in the 70s that more and more victims started coming forward. And when they went to hospitals, nurses, we had no policies, procedures. We had no idea how to care for these patients, nor an understanding of interpersonal violence. So nurses started getting together, and I am not able to control the slide. So if you could forward it. So as the anti-rape and domestic violence movements and the feminist movements began, shelters started opening up and rape crisis centers. And that is when the nurses started these sexual assault nurse examiner programs. Here in Maine, it was the advocacy community that started forensic nursing. They got a federal grant back in 1998, started teaching nurses how to collect evidence and a little bit about forensics, etc. But that federal money ran out. So they went to the legislature because sexual assault is a crime. So the legislature had a vested interest in promoting and supporting forensic nursing. So they coughed up enough money for a director, and we started the program really in earnest in 2003. And it really grew from there. And then when UNE got our large federal grant, we've been able to expand it. So we now have 4 people doing the work that one person used to do. Next slide.
So the question now is like, so why do we need sexual assault forensic nurses within hospitals, within the healthcare setting? And a lot of it has to do with before forensic nursing really started, hospitals and healthcare had no good response on how to provide that care. They had patients who checked in and sat in waiting rooms forever because they didn't know what to do. There were no policies. And when I say waiting for a long time, I'm not talking 1 or 2 hours. There are some patients sat for 5, 8, 9 hours within a waiting room just because the ED staff did not know what care to provide, what they could and could not do. So when they finally did bring that patient back, the triage nurse asked them to tell their full entire story. The primary nurse, if it was a different nurse, asked them their full entire story. The medical provider screening them also had them tell their full entire story. So all of that trauma of telling their story over and over and over within a very short period of time, it re-traumatized that patient. Not only that, the exams were interrupted. Yes, I am a former ER nurse. I know how busy that ERs get. But they didn't have that dedicated person to be one-on-one with them. So nurses were being pulled in and out of those rooms, and it was really fractioned care. It was interrupted fraction care. The evidence that was collected was very rushed. It wasn't best standards at that time. And they just didn't know how to really meet the survivors' needs during that time of crisis, just because they didn't know what they could do, what they couldn't do, what was best for the patient. So it led to a lot of re-traumatization just for asking for that medical care. So why we have forensic nurses is that we are that specialty one. We have that specialized training. We can provide that uninterrupted one-on-one care within that healthcare setting. We can take our time with our patients as well too. These exams are not short by any means. They can be a couple of hours. They can be 5 or 6 hours long because we don't rush that process. Even though we know that we are working within a busy ER, that doesn't phase us because that's not what our priority is. The priority is the person that's right in front of us asking for that medical forensic care. It led to a lot more consistency, not just within hospitals, but across the state as well too. And it did lead to better outcomes for patients. Now, medical forensic care can include, it is the medical assessment. It is a mental health and safety assessment. We are doing a full head to toe. We will identify and document any sort of injury that is on that person's body and also treat those injuries too. We will medicate them for any sort if they are having pain or nausea during this time, or even for prophylaxis for STIs and HIV as well too. We will collect that evidence and take photos of those injuries right as well too. Now, I know that you all see this list on your screens. These are things we offer patients. Patients have 100% choice on what they want done and what they do not want done. So this is not a nurse or healthcare provider walking in and saying, we are doing X, Y, and Z. These are services that we offer, and patients have complete choice. If there's something that they don't want, they tell us, and we move on. We do not question that. Because our key points is we really want to make sure that the patient feels like they are in a safe environment within that hospital setting. And sometimes that may be letting them know that security is walking the hospital just to make sure that it is safe. They may fear that their abuser is out in the parking lot waiting for them, and we can have police sit in the parking lot when the patient leaves to give that safety there, based on what law enforcement is doing right at that time. We discuss every option with the patient because this is a patient-led exam. This is not something that we are mandating or dictating. This is what needs to be done. We explain everything, give them the options, and it's 100% their choice. And they can end this at any point. If halfway through that they were like, I'm done, I'm stressed, I want to leave, we will let them leave. We don't force them to stay, but they also know that they can always come back if they want more care for this here. We will also talk about all the medical treatment options that we can offer, especially with medications for like STIs, HIV, for pregnancy, and also to catch them up or start them on certain vaccines that they may not have had. So these are things that are our key points with absolutely every single patient that we serve. When it comes to the evidence side, because there's a lot, everyone wants to know like the evidence and really does think that CSI part of that. There are some time frames that we do work within. They are more recommendations. Usually we can collect any sort of evidence based on the type of assault within 5 to 7 days. We can push that out to 10 or 12 days based on whatever the circumstances are. But if it's a penile, it's like anal assault, it's like a 3-day window here. One thing that we also do, the same level of care that we offer for adult patients, we offer that same level for minors as well too. And under Maine law, minors can consent to this exam, and we do not need parental consent whatsoever. So we explain everything at a level that minor does understand, and they have the same options as an adult patient has. Under Maine law, the medical forensic exam and the evidence in meds, they are all covered under Maine victims comp. So the medical forensic care is free, and every hospital bills victims comp for it. So most likely, most victims will not get bills. Patient does have to consent. It's because this is a different type of a medical workup that we explain the full process to them, and they can consent to whatever parts that they want and whatever that they don't want. They can tell us that, like, I do not consent to X, Y, and Z, and we are going to respect that choice. Under Maine law, victims of sexual violence, they do have the option of reporting this or being anonymous. That is their choice 100%. If at any point, if someone is anonymous, law, they can report it whenever they choose to. That is their option if they want to. Not only that, when we collect the evidence, law enforcement crime lawmakers, they have to hold that evidence for 20 years, which is a huge step because when this process first started, it originally was only 90 days. Now we're up to 20 years. So patients and victims have options. If they want to report 5, 10, 12 years later, they have that option, and the evidence, the potential evidence that was collected has been safe the whole entire time. So it gives victims a lot of options to work with in their own time frame as well. So when it comes to working with a team, most forensic nurses, we are a solo practice because these exams can be very traumatizing at times, because we are asking the survivor to tell us in their own words what happened to them. So that's why we are one-on-one with them. We will pull in other providers if there is a injury that does need that medical care first. If there is strangulation, because we need the medical provider not only to do that assessment with us, but to put some orders in for like imaging that nurses, we just don't have that capability to order those. We will discuss with not only the provider, but with the advocate right as well about safety planning for discharge, because we want our patients safe when they leave that hospital setting. We will work with the pharmacy side to help them get the meds that they need while they're in the hospital setting right then and there. Our advocates are a key part, and they definitely add into this as well too. Outside of providing that medical forensic care, we do help prosecutors kind of understand what we do and why we do certain things, as well as we can help them prep certain cases if they need that certain prep with language and like the neurobiology of trauma, so that prosecutors can understand, like, this is why my chart looks like this. This is why the patient has said this with me, but 6 months later has said something else to police. Like, this is the medical reason why more is coming out versus when compared to when I was giving them care. So we do help them understand some of that neurobiology of trauma, of like what the victim has gone through.
So before we get to the case, we
Yeah.
have a lot of good questions. So I'll just throw them out. Paul and Sean, you can decide who's going to respond. So the first one is there a common age range for those who have experienced sexual violence and trauma? And I think that question can also extend to the range of people who experience sexual trauma. So throwing it out to both of you.
Well, when it comes to sexual trauma, it can happen to anyone at any age. I have provided care. Sadly, the youngest patient that I had was 5 years old. The oldest patient that I had was 82. So it can happen at any point within the lifespan, and anyone can be a victim of sexual violence.
I would say too that a lot of the people that come forward tend to be in the mid-adolescence up to the 30s and 40s, though more and more people in other age ranges, certainly children, are brought in by their parents. But we have elderly people that are being trafficked here in Maine, and we have elderly people who are being assaulted in long-term care facilities and in their own homes. So I agree with Sean, it's the whole age range.
And all genders, I think.
In all genders, yes.
Yes, absolutely.
Yep. So there is another question about consent. If someone is incapacitated in some way or other, you both smiled at that one. How do you achieve consent?
This is a great question. And it's something that we've tackled here in Maine on a number of levels. We have drug facilitated sexual assault is alive and well. And if we have somebody come in, if they're drunk, then we will let them sober up so that we can get consents. But if we have somebody that has been beaten and they're unconscious and they have to be intubated, but there are signs that they were sexually assaulted, we have a law here in Maine. We were the first state in the country to do this, that allows forensic evidence to be collected on that patient without consent. When the patient regains consciousness, and that evidence is collected, turned over to police, and it's held with no identifying information, and there's a whole process. But when that patient regains consciousness, they decide what to do with that evidence. And if they want it destroyed, we honor that. But what we have found is that this law has provided choice to probably 3 or 4 victims a year. And it's also been of great assistance in sexual assault homicides. Now, if we have someone that is nonverbal and there are signs that they've been sexually assaulted, that's a whole other level. And we will involve guardians. And if we can't find a guardian, we will get adult protective involved. So I'm hoping that answers the question. You do have anything to add, Sean?
No, I think that sums it up extremely well. I mean, I will say Maine was the first state to have this law. I do know that 2 other states have done it, and those 2 states are escaping me at this moment, I know. But I also believe that there's another state looking at our law to implement something like this in their state as right as well too.
Yeah. That was really helpful. Thank you so much for that. Phil has sort of a 2-part question here. And you can see it in the chat, but are there procedures that allow for interpreters if the patient is non-native speaking? And a second part of that is, are there protocols for what is shared with the person who's doing the translation relative to the person who is helping them to communicate? So what are the protocols around that?
I'm only smiling because I kind of hate giving this answer, and the only reason why is it's going to be dependent on the hospital system and what their protocols are. We know that a lot of hospitals, especially within Maine, do have that iPad on wheels, that they are contracted with a interpreter service to provide that care. And all of those interpreters are HIPAA compliant and so on. But unfortunately, it really comes down to whatever that hospital policy is, because it is going to look different at hospital A versus hospital B, which is in a different system. So there are some protocols, but it is hospital dependent. And I wish I had a better answer, Phil. Unfortunately, I just don't.
Holly, did you want to add to that before I go to the next question?
I think, yeah, I think it's really important that hospitals have the capacity to access really good medical interpreters that have also been trained in the language of interpersonal violence and sexual assault, particularly. And that's not always the case.
The next question is one I think probably many people have. So thank you, Rose, for asking this. She says, I may have understood, but it was mentioned that you provide care to perpetrators as well. Can you speak about the portion more if I understand this correctly?
Yes, we certainly would provide care for any person who has suffered any kind of injury, period. Very rarely will a perpetrator appear at the hospital for injuries that they suffered while perpetrating the assault. Generally, they make their way there. They're brought in by police, and police want us to collect evidence and certainly treat any injuries. One of the glitches to that is that perpetrator, particularly if brought in by police, is often reluctant to sign a consent form for treatment. And then we can't treat them in any way or collect evidence. And we also have to have a warrant to do that. So it can get a little complicated. It doesn't happen very often, but we certainly do. We'll treat anybody who has been harmed.
So I'm all set with that one.
And can I circle to the most recent question that Katie put in, since we already talked about the interpreters? you can always advocate, but it really comes down to the contract that that hospital system has signed with that service. And it's up to the interpreter service to really provide that training to their interpreters. But it's something that you can bring up to the hospitals to make sure that that's in the contract so that they know they are going to hear some pretty awful things while they are interpreting what we are saying and vice versa. So unfortunately, I mean, it really comes down to whatever the contract that that hospital system has with the service that they use.
Great. Well, great questions. We're going to move on to the case, but I want to just put out, there was a great question from dental hygiene about oral assaults that maybe when we come back, we can ask you again.
Yep,
Okay.
Absolutely.
Thank you for
absolutely.
your answers.
All right, so we are going to be heading out to breakout rooms soon, but I want to lay this case out, which will be talked about within every breakout room. So there's a 20-year-old female identified patient that woke up in a strange hotel room with pain down there. Her last memory was being at a frat party, and she is presenting at a walk-in clinic facility. So these are kind of the prompts for each breakout room. So first, introduce yourselves in the profession or program that you are in. There will be a scribe. I'll talk about that in the breakout rooms to kind of take notes. And these are the 3D discussion questions. Now, every breakout group doesn't have to hit all three because if the conversation is really good on one question, let that conversation go. Just let it continue. So don't feel like you have to answer all three questions here, but it is what would a trauma-informed approach look like? My profession will focus on the following priorities for this patient. And what have you learned today that will inform your future practice? So those are the three kind of talking points there. And I'm going to turn it over to the powers that be to send people to breakout rooms.
Looked like there was a lot of great discussion going on. And we'll take these last 6 or 7 minutes to answer questions and to hear from you. If you were a scribe, please put takeaways from your breakout room in the chat so that we can see what everyone talked about.
Wow, that went by fast.
Go by fast.
Whew, my head is just like, whew. And lovely participation. It was good conversation.
So as everyone is coming back in, I'll just go based on group. So group one, I don't know if anyone from group one wants to if the scribe wants to come off of mute and kind of talk about what your group kind of talked over here. So we'll start with group one.
I don't know if anybody else took notes in our group, like we didn't have an official scribe, but we just talked about, or something important that we learned in our group was that, like, you know, making sure your patient knows where you are physically with them at all times, like making sure that they have you in their line of sight is an important way to like establish comfort for them, because they've just been traumatized and there's always that like underlying fear of like being re-traumatized. So like as their provider, like making sure you're in their vision was something we talked about. And then somebody mentioned from the PA program with like past training on informed care is to also make sure that you don't like keep questioning them over and over again about their history, like trying to establish it being a one-time thing.
Great. Anyone from group two?
I could speak from our group. Group two, we had a really great mixed group of dental hygiene, PA, comm, and criminology. So we had a really great mix, a lot of perspectives, and a lot of the students had very similar themes of making sure to use the right language, making sure the patient is safe and feels safe, and building that trust. A dental hygiene student even spoke about even writing something on a piece of paper in case something doesn't want to be spoken out loud. So that was a really nice takeaway that resonated with me.
Yeah, I mean, that's always a great thing. Letting the patient communicate to us in their own style is always key. Group three.
All right, hi, I'm from applied nutrition, so I'm a little bit out of the scope, but within the scope, because of course nutrition is relevant. We had mostly nurses and medical students, and so our approach is very similar to group two, where it's really important to make sure that that patient feels safe above all. So one of our members had done a recent research paper about this actually, and she said it's really important to make sure they have something warm to drink, a blanket, making sure that your bedside manner is very calm and approachable, and that you're explaining every step of your assessment, making sure you get their permission. And can I touch you here? Can I look here? Can I do this? And making sure that they have their autonomy restored.
And because I know we are running low on time, and there was a question before we did the breakout sessions about the oral. Shelley, if you saw that very specific question.
It was a question about, are there any specifics when a person has experienced oral assault?
When it comes to oral assault, protocols are going to look very different because an oral assault is not going to be the same for every single patient. The injuries may be different for patient one versus patient two, and in lack of a better phrase, the object that was used to create that oral assault could cause more injury or less injury there. It's really having a trauma-informed approach when looking into somebody's mouth and assessing someone's mouth, because it's a very small area, but a lot of damage can happen very quickly. So unfortunately, I mean, it's really going to be case-by-case basis. I will say patients who have been victims of oral assault, they may have that trauma response in the dentist office months or years after, even with doing a dental cleaning or giving them the Novocaine to do a root canal, because that trauma is always going to be there. So you may see some trauma responses within the dental field for people who have been assaulted or orally because of their trauma history.
And I just want to emphasize that we teach the nurses how to do a very comprehensive oral assessment. There's a question that I want to address. Can you briefly describe what a case would look like for a SANE nurse, and are all SANE nurses ER nurses? I want to just say that two things. No two cases are ever alike, and that's one of the challenges of being a forensic nurse. You never know really what you're going to be walking into. That's why the education we give is ongoing and very comprehensive. Not all forensic nurses are ER nurses. You don't have to be. We have oncology, OB, ICU, med-surg. They come from all areas of the hospital. And when they have a sexual assault patient, that is a one-on-one patient, and the ER knows that they're going to be with that patient for several hours. So thank you for that question, Brooke. Back to you, Sean.
Well, we have 2 minutes left. Is there a group that really wants to say what they talked about?
I could briefly go over what we discussed. I'm not exactly sure what number we were, but we talked a lot about creating a safe environment for the patient coming in, making sure that everything that was done with the patient's consent, as far as how far that they would want to go with any individual intervention, or like having a kit done on them, having a point person that kind of establishes maybe more rapport with the patient rather than having a bunch of people asking the patient questions. And then just a lot of general stuff like having empathy, having respect for the patient, establishing resources that they can continue to use, like therapeutic stuff, and having maybe the person come with them to be their advocate, someone who can follow them and be involved in their care long-term in their life.
Thank you for that there. And Emily, feel free to reach out to me, because I know we do not have time to answer that question in the 15 seconds that we have left. So feel free to reach out to me, and we can talk about that more. And I want to thank everyone for being here, and I'm going to turn it back over to Shelley.
And thank you, Sean and Polly, and you were amazing. And thank you to everybody. You asked incredible questions and were involved. Our center staff, me, Michelle, and Chris, thank you so much for being here. And our next event is going to be on the 23rd, and it's Thriving Waters, Navigating the Health and Business of Aquaculture. So we're going to be looking into the health of the environment, something we are very committed to in the concept of One Health. And we hope that you can all attend. I'm reminding everyone to do the attendance sleep. And thank you so much for being here. I know you learned a lot. I learned a lot. Thank you so much, Polly and Sean.